If you're a pre-med, go check out our new podcast, Ask Dr. Gray Pre-Med Q&A. You can find it at askdrgray.com. This is Specialty Story, session number 47. Whether you're a pre-med, a medical student, or a resident, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information you need to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here every week. This week, I have a great guest to talk all about an awesome surgical subspecialty. But before I jump in there, I just want to remind you, go check out Ask Dr. Gray Pre-Med Q&A if you are a pre-med. If you're not a pre-med, go tell all your pre-med friends. I know that you are out there. You have people asking you, what did you do to get into medical school? Just point them in the direction of Ask Dr. Gray Pre-Med Q&A or all of the shows that we host at mededmedia.com. Now, today I have Dr. Westley Ohman. He is an academic vascular surgeon in the St. Louis area, and he's been out of practice only for a short few months. But in that time, he's gained a lot of great experience, and he is going to talk all about vascular surgery in today's episode. So let's go ahead and dive in and find out how Dr. Ohman was first exposed or first formed an interest in vascular surgery.
I had exposure to vascular surgery, at least from an engineering standpoint as an undergrad, with some of the earlier stent grafts for aortic aneurysms. Really didn't make the decision until my late in my third year, really going into my fourth year with my sub-Is. I was fortunate to have really world-class mentors, both on the cardiac and the vascular side of things, and they helped guide my decision, and really, the cardiac guys really supported me going into vascular because I think they saw that's where my interest and my skill set lie more than on the cardiac side.
What was it with your interests and skill sets that you think led you down that path?
More of the interventional approach, where you can treat an aneurysm in one room with two small needle pokes in the femoral arteries, and the patients go home the next day. Whereas in the next room, you can be doing an open aneurysm, and the patients can stay for a week. And kind of really deciding which patient benefits from which, and really trying to master both open and endovascular surgery. I was fortunate enough to where my mentors would, let me manipulate the wires when it was safe to do so, even as a medical student. And so that just kind of whet my appetite, and it only went from there.
What other specialties were in the running as you were going through your sub-Is through your fourth year, trying to figure out what you wanted to do?
So I thought about cardiac surgery, of course, and my med school was one of the early partner trial sites. So I got exposure to TAVRs, and they were just starting to get MitraClip and other cardiac interventions. And I found them interesting, but for some reason, I still can't explain the kind of the technical aspects of doing a fenestrated aneurysm repair. Just appealed more to kind of how I approach problems and think about things. And then I thought about neurosurgery, and really more of the interventional neurosurgery as opposed to true neurosurgery. And I know as a vascular surgeon saying that someone has worse outcomes than we do with amputations, but that's really kind of the case with a lot of the interventional neurosurgery that I saw. Was that even if the clot from the MCA was pulled out, the patient might not have had the best outcome, and I didn't know if I would be able to weigh on that for the rest of my career.
Okay. What traits do you think lead to being a good vascular surgeon?
Spatial reasoning more so than any other surgical discipline. As we we do open surgery anywhere in the body, and that really kind of understanding not just where the blood vessel runs, but where is the nearest muscle insertion or origin, and how are you going to be able to tunnel your bypass graft, or how are you going to get exposure to that artery, and then in the belly, really being able to not only understand where the important organs live, but also being able to kind of manipulate the space in terms of where you're going to run your bypass. And then more than anything else that I saw in my general surgery training was a really demand for technical precision. Vascular surgery has a way of humbling you for even a millimeter or two off one way or the other in your anastomosis, and that can mean the difference between successful anastomosis versus coming back at night to revise it.
It's interesting when you talk about the anatomy of every place. I would think that vascular surgery may be up there with a general orthopod. Like, you have to know every inch of the body,
Yep.
the anatomy and all of that to successfully operate on somebody.
Yeah, I joke with some of my friends from medical school that I'm kind of I'm a practical radiologist, in that they know the anatomy from looking at pictures, but this is something that, in my practice on a daily basis. Today I was in the chest and the pelvis and the leg in subsequent cases, and that's just kind of how or what vascular surgery demands of you.
Wow, that's pretty cool. As somebody who loves anatomy, that's the only class I liked in med school. Talk about the types of patients that you're treating. So you talked about chest and pelvis and other stuff. On a day-to-day basis, what kind of bread and butter things are vascular surgeons treating? What kind of patients are they seeing?
Sure. And I say this from an academic standpoint, but I think it's going to be true for even those in the community as well, is that a big portion is going to be the end-stage renal patients, not only in terms of either access creation or maintaining a functioning access for dialysis, either through revisions or fistulograms, but also all the peripheral arterial disease that comes along with kind of the disease burden with end-stage renal disease. And then the smokers, if you want to think about, your average VA patient, kind of encapsulates a lot of vascular surgery from a general standpoint. And they're the smokers, they're the diabetics, they're the ones that don't necessarily take the best care of their body, and so they get peripheral arterial disease, or they get an aneurysm because for whatever reason we think the nicotine activates the MMPs in the aortic wall, and that leads to degeneration. But from an academic standpoint, I also get a lot of the referrals for infected either endografts or grafts or aneurysms in and of themselves, and sometimes that's just plain unluck, or bad luck rather, for those patients.
You mentioned community versus academic a little bit. Talk about, for you, the decision algorithm for staying in an academic setting versus going out to the community.
Sure. I actually looked at jobs for both community and academic. One of the things that I think made me stay in academics, of course, there was a job available for me, which, when you're going through looking for a job, the academic jobs are always posted about 4 to 6 months after the private practice job. So no one ever truly knows when an academic job is going to pop up because of the difference in funding cycles. But it goes back to the early exposures with the complex endo interventions, and kind of pushing the limits of what we can do from an interventional approach or a minimally invasive approach, while still doing right by the patient. It's very easy to do something to a patient, but determining if it's the right way to do it, and then pushing the envelope in terms of what the fenestrated devices or the branch devices can tolerate, and how can we limit the physiologic stress, I think, on really aortic surgery patients is kind of what drove me towards or kept me in academics. And I've always wanted to be a big aortic surgeon because I found that disease process in terms of aneurysms and dissections fascinating, and a lot of the smaller hospitals or even the mid-sized hospitals just don't have the resources to support that very sick and very challenging patient population through no fault of the hospital. It's just that's not what their mission is or what their buildup is, and it takes a very specific type of place to do what I kind of always saw myself doing as a surgeon.
It's funny you mentioned that. I kind of always joke that you have to love your body parts, and so it sounds like you just love the aorta and that whole disease process.
I do, for better or worse. It's a cruel mistress.
And you can never determine. It's just something you latch onto and go, I don't know. I just like it. A lot of students love the hunt and the diagnosis of a patient. As a vascular surgeon, what percentage of patients are coming to you already diagnosed and you're just fixing whatever that is?
Probably 2/3 overall. And I have to say that with the caveat of I also do thoracic outlet syndrome at one of the biggest, if not the biggest, thoracic outlet syndrome referrals in the country. And so for nearly 100% of those patients are coming with a diagnosis or a diagnosis in the ballpark. But for the remainder of my patients, I'll get referrals from the hematologists or the rheumatologists of kind of hey, we found this on the scan. What do you think about it? And we have this dynamic interplay in terms of, is this an atherosclerotic process or is this more of an inflammatory process like a Takayasu's or a segmental arterial medialysis? And so there's, once you get outside of the pure, simple, patient has end-stage renal, they need access, or they've been smoking and they have peripheral arterial disease. There's really kind of a lot of, not really boutique, but more esoteric diagnoses that can be made in an interdisciplinary process. And that's something that I also saw kind of a lot of in the academic center. And it may exist in the community center. I don't have enough experience in that aspect of it to really say to that. But, there are going to be days in my clinic where, the diagnosis is made for the patient before they get there, and I'm just talking to them about what I can do or how we can confirm that diagnosis. But for a not insignificant 25 to 33% of my patients, there is usually some sort of interplay between myself and another consulting physician about, hey, what do you think about this or this? But in terms of, a lot of my diagnoses aren't made from the subtle physical exam findings. They're important, but it's really a very imaging driven specialty.
Describe a typical day.
I would say there isn't one, and that's kind of a selling point for me. But if I'm on call at a major center, I could very well get a ruptured aortic aneurysm and go do that while dealing with a gunshot wound to an extremity and having to figure out how I'm going to reconstruct that and what conduit I'm going to use, and then bouncing back to more of my elective cases. But it's very easy to go from starting your day with a carotid endarterectomy and then going to a lower extremity peripheral intervention in the cath lab, and then bouncing back upstairs for, either a bypass or a big belly revascularization, just depending upon what's on my schedule for that day. So, outside of clinic days, I really don't know what's going to come my way, because even if I'm not on call, if we happen to get swamped, then I may be being pulled into some other cases. And so being able to be flexible and kind of offer the full toolkit really allows my day to be as variable as the hospital needs it to be, or as I want it to be.
What percentage of your days are clinic days versus OR days?
Right now I have 1.5 days of clinic a week.
Okay. So a lot of OR time.
A lot of OR time, yes. Yeah. Well, it's balanced between not only the operating room, but also the cath lab or the interventional suite, just kind of depending upon, what the patient needs and how can I meet that.
Okay. Do you have to take a lot of call?
I'm in one of those rare groups where I have 10 partners, 9 of which still take call. So it ends up being a 1 in 8 or so call. So I'm on call a weekday, usually every other week, and then weekend call every other month, which is significantly better than it was when I was in training. And outside of those large groups, it's pretty easy to still be in a Q3, Q4 call. Now that being said, at Barnes, where I am, we're a major referral center. So even though it's an infrequent call, it's still a very busy call. I'd say, probably half of my calls I'm up operating most of the night, if not all of it, and then still running a full day the next day. And the other half I'm, interacting with the referral line or fielding inpatient consults that don't necessarily need to go to the operating room. So it's still pretty busy. But I know some of my friends who have taken more of the community jobs. If they're on call and it's something outside of their wheelhouse or what the hospital doesn't have support for, they usually ship it on, unfortunately, my way sometimes. But it all comes around. So it's not too burdensome. Although going into vascular surgery, there should be the expectation that there are going to be emergencies, because not a lot of our cases, when something goes wrong, can we really sit on it until the next morning.
It's not pathology.
No.
What do you feel like as a vascular surgeon you have enough time for life outside of the hospital?
I do, and I say that with the caveat of I'm married to a general surgery resident who's in her 4th year right now, and we have a toddler and 2 dogs, and it's tough. Sometimes we're playing hot potato with the baby, but since I've finished training, life's gotten significantly better, and regardless of what my wife is doing, I have time for what I want to do in terms of my family and in terms of my career as well. It's just kind of finding that right balance. And for my wife and I, that right balance is a wonderful nanny who, was here until 8:00 tonight because my OR schedule ran late. And it's just kind of finding some flexibility that allows you to stay in the hospital late on the rare night you need to, or the occasional night you need to, and still get out on time.
Okay. What does the residency, the training path look like to become a vascular surgeon?
Yep. So there's, at least in America, there's 2 routes. There's the traditional 2-year fellowship after a 5-year general surgery program. That's known as a 5+2. And then there's also what's termed the 0+5, which is 5 years of some amount of general surgery and a lot more vascular surgery divvied up. My program did it half and half for the first 3 years, and the last 2 were only vascular. And that allows you board certification only in vascular surgery. And from that, I know some people who have gone on to do cardiac fellowships or critical care fellowships, just to kind of, I think, augment what they can offer. But I feel like I came from a 0+5 program where I could do whatever I wanted anywhere in the body that I needed to be. And I don't think either pathway is the right way. I don't think there's a wrong way to go. I certainly have noticed that kind of I'll say co-fellow, for lack of a better term, who came from general surgery training when I started my 4th year, was absolutely more comfortable in the belly. But by the end of it, I think we were roughly equivalent. And I certainly felt like I had stronger interventional or endovascular skills because I didn't learn laparoscopy, whereas he did. So it's, it really kind of takes some soul searching from the student as to which pathway they think is best for them and what skill set they want to have. That being said, all of my friends who have done general surgery and then vascular don't touch a laparoscope. And in fact, I'm probably more likely to touch one than they are, just by accident.
Do you think somebody who's looking at vascular surgery and knowing those different types of training paths should they be looking at one over the other depending on where they want to end up in their career, an academic setting versus out in the community?
I don't think so. I think that what's more important is the quality of the training program. There are certainly some 5+2 programs that will prepare you for a very successful private practice. And there are some 0+5s that will prepare you for a very successful academic doing the big cases, and vice versa. I think each program has their own individual strengths. And when I sat down 6 years ago or so to make my rank list, my first 3 were integrated programs and my 4th was general surgery. So, I would really recommend kind of figuring out what they want their life to look like. And they may not know that. And so, they may think that 5+2 is a safer way to go because they have their general surgery training to fall back on, which is not a bad decision, but just with the mindset that a lot of vascular surgery is moving more towards 95 to 100% vascular surgery just because of what we can do and how we can do it expanding every year.
How competitive is vascular surgery?
The fellowship is still fairly competitive. I think there's slightly more applicants than there are spots. And then in terms of the 0+5, when I applied, it was more competitive than dermatology. But I think as the number of spots have increased, that kind of mismatch has fallen off a little bit to where it's not quite as competitive as some of the integrated plastics or ENT programs, but we still probably have 80 applicants per one spot per year, and we interview about 20 to 25 of them. That's for the 0+5, and then for the fellowship, numbers are probably roughly a little smaller.
Do you see the big academic centers changing from the 5+2 to the 0+5? Are they adding on the 0+5 on top of what they already have?
That's kind of a big debate that's roiling the upper echelons of the SVS, so to speak. So a lot of the 5 or the 0+5 programs were actually born out at the big academic centers. Michigan was one of the first to have a 0+5, as was Pitt, as was Dartmouth. These are big names in vascular surgery. Here at WashU, we keep both pathways open. We are committed to matching each pathway per year, and part of that is they get complementary training, like my co-fellow and I did, where it was always nice having someone to I bounced general surgery questions off him, and he bounced endovascular or vascular specific questions off me, and I think that made for a better learning environment. And then there's always the big academic centers that don't have a 0+5, and I won't name names, but some of the bigger leaders in vascular surgery right now said that they will hopefully never have a 0+5 at their program. And so it's still, even though it's been out for almost a decade now, it's still a very kind of polarizing topic for some of the senior people in the discipline.
Interesting. Okay. For a student, since vascular surgery is competitive, for a student who's interested in going into vascular surgery, what should he or she be doing to become competitive?
Unfortunately, just like for everything else, it probably comes down to having a reasonable step 1 score, because a lot, that's going to be a very easy, quick and dirty screening outlet for that. But one of the things that I found extremely helpful, and I've noticed as the years have gone on, is that vascular surgery is a very small field. And I think more so than general surgery or a lot of the other surgical disciplines, doing a sub-I is absolutely critical. Getting your name in the door at different places, and even if you can, getting letters or phone calls from not only your home institution, but other institutions as well, really goes a long way towards building a competitive application, because it does show, especially at the 0+5 level, an exploration and an interest. And there's still that worry about people falling out of the pathway and having an empty spot or an empty hole in their schedule for the next X number of years where you were supposed to be training. And so having that being able to kind of show that what you're getting into, I think goes a long way. And that's certainly something that we look for, and I look for when I'm interviewing applicants.
For the osteopathic student listening to this who is diehard into vascular surgery, do you see any negative bias towards the DOs in the field?
Nothing overt, and nothing that certainly that I've been privy to. I know that we've interviewed from some DOs in the last several years, and so it's not that we or anyone else that I'm aware of has a blanket no DO policy. I think it's just a lot of the big programs for vascular surgery aren't associated with an osteopathic school. So I think that's an extra kind of hurdle that the student has to go through, is to show that they've investigated it and have this commitment to it. And if they can show that, I think that actually goes a little bit further than the allopathic student who, comes from a program that may have a great reputation for vascular surgery, but didn't necessarily show as much interest or build as competitive a application packet.
Okay, that makes sense. What opportunities are there to subspecialize as a vascular surgeon?
Within vascular surgery, there's kind of several ways to kind of make your niche. There aren't any formal ACGME type fellowships, but the first that will probably come to anyone's mind is there's advanced aortic endografting fellowships. Cleveland Clinic has one. The Mayo Clinic has one that's also rolled into a complex aortic reconstruction fellowship, as does UT Houston, where I went to medical school. These are big aortic referral centers, and so they attract the aortic super fellow, so to speak, to learn those techniques. But heading out into practice with vascular surgery, it's very easy to build a very heavy, thoracic outlet syndrome practice if that's where you want to make your mark. Because if you can do it well and show consistent outcomes, those are patients that will come to you, and the referrals will come to you as well fairly easily. A lot of people in the community end up either specializing or selling a specialization in lower extremity limb salvage or venous reflux treatments for venous reflux, because those are disease processes that I think we have kind of undersold as a society or a medical profession. And there's always one guy in town who's the carotid surgeon, just like the thyroid surgeon. If you get good outcomes with your carotid endarterectomies or stenting and show that your stroke rate is lower than other people, those referrals will also continue to come as well. But in terms of established training pathways, there really aren't any besides the aortic surgery. Beyond the general training, it's just kind of how you want to market yourself.
For the future primary care physician listening to this, what do you want to say to him or her to allow them to take better care of their patients who you're going to see eventually?
First of all, I would thank them and tell them that they are probably my very best friend, because a lot of the management of, at least the medical management of vascular patients, and I'm not trying to settle it to just the carotid or just the lower extremity patients. A lot of it is driven by the primary care physician in terms of following the JNC guidelines or the AHA guidelines in terms of the best medical management of those. And I talk to, I'd say probably a third of my clinic patients. I end up getting a phone call or giving a phone call to the primary care physician just to kind of pick their brain about it. But I think it really is under-recognized in a large portion of society. Everyone thinks about carotid disease and stroke, but lower extremity peripheral arterial disease and claudication and critical limb ischemia are fairly quick to pick up in terms of simple questions about claudication, or do you have rest pain when at night requiring you to dangle your leg off the edge of the bed? And those are pretty quick and easy things that can prompt a referral to me and really impact a patient's overall lifespan. If they can't get their patient to lose weight because the patient can't walk because their legs hurt, I can help knock that peg out of the way and get the patient back onto the pathway that the PCP may have at least outlined for them. And so it's critical. Of all of the surgical disciplines that I looked at or that I've been exposed to, I think a lot more medical management happens in vascular surgery than a lot of the other specialties. I have to be kind of, a PCP and a surgeon myself, most of my clinics.
What other specialties do you work the closest with?
The cardiac surgeons, just because we do a lot of combined cases in the chest. I did an ascending to innominate artery bypass today with one of the cardiac surgeons. When we do the open thoracoabdominal aneurysms, those are combined with the cardiac surgeons. I have a lot of discussions with nephrologists, not only from the, this patient needs dialysis access, but also the would this patient benefit from a renal artery stent? That's a fairly common question that I get. The hematologists and I bounce things back off each other in terms of how do we manage venothromboembolic events and what's the best management of those. And then, particular to being an urban level 1 trauma center, we interact with the trauma team on I won't say nearly nightly basis, but sometimes it seems like it's every night I'm on call, we're interacting with them. And it really, we interact a lot with radiology. I already touched on primary care, who are, I can't say enough about a good primary care physician in terms of my vascular surgical patients. And then, a lot of places, I'm very fortunate where the turf wars are they were fought by a generation before me, so I don't have to fight them, but we do interact a lot with our interventional radiology colleagues in a congenial relationship and not in an antagonistic relationship. Same thing with the interventional neuroradiologists. They have really done, they've really made a name for themselves in the intracranial work, and we do most, not all, but most of the extracranial carotid disease. And so if those issues hadn't been as settled, I think it might be a little bit different, but I have very good relationships with just about everyone in the hospital.
Talk about that. I'm glad you brought that up, because that was the next thing I was going to talk about. Yeah. Are the turf wars, because I've had an interventional radiologist on before and other interventionalists, and it seems like vascular's the new uncharted territory for some of these other interventional subspecialties. And so from the vascular surgeon standpoint, or for somebody looking to get into vascular surgery, is that something they should worry about as far as limiting their scope of practice in the future?
No, and I think that's because a lot of the blame for kind of vascular being open for other specialties is that we've done a poor job of defining what's the best treatment option for this disease process. And the interventional cardiologists or the interventional radiologists have the skill set to treat those patients as equivalently as I do in terms of putting a wire across a lesion and putting a balloon or a stent in. The thought process and the way that I think the vascular surgeons can really sell themselves is, yes, I could treat that lesion in the superficial femoral artery, but I also have the ability to do a bypass, and I have the ability to think about, am I burning any bridges by doing this? If I put a stent here, am I ruining where I can sew a bypass into? And if we can define who benefits from what procedure, and then also market ourselves as, well, we can do this, but we can also do the open surgical bypass. We can be your one-stop shop for lower extremity work. I think that's how we either protect our patient population or start to grow it. Because I certainly won't sit here and tell you that there aren't interventional radiologists that can do phenomenal work in the peripherals, or the cardiologists can't do good work in the in the renal segment, whatever the case may be. But I really think it as not only someone who can put a hole in an artery and fix a remote artery, I can also make an incision and provide a definitive fix to that problem.
Okay. What opportunities are there outside of clinical medicine for a vascular surgeon?
There's, the first thing that always comes to mind is industry. A lot of the early advances in terms of, the first stent was developed by a physician, admittedly not a vascular surgeon. And then a lot of the newer stent grafting was, at least in America, was pushed by a vascular surgeon or helped develop by a vascular surgeon. And that we have at least where I am, we have a very large industry presence, and we're very active on clinical trials. The IP world for vascular surgery or devices in general has changed quite a bit into where it's not like it used to be, where I have this idea, I'm going to take the idea to the industry, be it Gore, Medtronic, or Cook, and they'll run with it, and I'll just sit back and collect royalties. I think those easy picking days, so to speak, are gone. They really want to see an idea kind of almost brought to the market in terms of the background studies and the safety and efficacy studies, and ideally if they could get us past the feasibility into the pivotal trials. I think that's where a lot of the companies really see themselves making an investment in a design or an idea that a surgeon may have. I know some of my partners from the more basic science side are working on small drug molecules and working with industry from that standpoint. And then one of my former partners who moved on to the University of Michigan was really big in kind of the buzzword of nanotherapeutics, and kind of pushing the envelope of how do we augment devices with small drug molecules, for lack of a better term, to kind of bridge both the device industry and the pharmaceutical aspect of it. And then there's always the kind of the policy standpoint. As I mentioned earlier, vascular surgery kind of hits on a lot of different disease processes that unify different body areas. And so I know a lot of vascular surgeons who have tried to move into more of a healthcare policy standpoint from outcomes, looking at not only the vascular system, but the cardiology or nephrology world as well. But in terms of the main thing, and this is maybe an academic bias, is that there has to be a healthy relationship with industry, and that right now means devices, balloons, grafts, stents, things of that nature. It's really more the exception for the small drug molecules.
Okay. What do you know now about vascular surgery that you wish you knew before getting into it?
Oh, geez, that's a very loaded question. When I was in training, it was, especially the last couple of years, it was definitely, I kind of cursed the middle of the night. I should have gone to a place that's not a major level 1 trauma center, because I don't really like operating that much in the middle of the night. And, looking back on it, I really see that the trauma situations for lack of a better term, were really the ones where I grew the most as a surgeon. And something that in that moment I was really able to curse and be tempted to throw an instrument. I look back and I see that, that was an opportunity to learn how to approach new problems in a time-sensitive manner, and I really think it made me a better surgeon. Would I pick vascular surgery over again? Absolutely. Just with the caveat that there are going to be a lot of nights and late days if you're going to do the big cases. If you want to design your practice to where you are treating venous reflux all day, then you're not going to have any inpatients, and you're going to live a very comfortable life. It just kind of depends on what you want.
What body part you love.
Yes, exactly. What's your organ?
What do you like the most about being a vascular surgeon?
I like being able to treat any disease process or any blood vessel disease process outside of the head and the heart, because it always keeps my days different, and I really enjoy interacting with not only other surgical disciplines but also other medical disciplines in terms of approaching and managing those problems. Because not every patient that comes across me needs an operation, but almost uniformly I'll be interacting with either their primary care physician or some sort of medicine subspecialist to help provide some input on a disease process. So I'm still treating patients even without a scalpel or without a needle.
What do you like the least?
Not operating at night.
I was waiting for that one.
I've done that a few times. Yeah. Honestly, I kind of joke with my trainees, but there really is nothing more humbling than vascular surgery. It is very demanding from a technical aspect, and sometimes I do find myself losing significantly more sleep now as an attending than I did as a trainee, in terms of, oh geez, did I throw that stitch right, or did my trainee throw that stitch right, or is it okay enough to where I can leave the operating room, or do I need to continue working at this problem? It's not that I like the challenge, but it definitely is starting to wear on me, and that's something that I'm starting to explore with my senior partners. And it's how do you deal with that, and how do you not let it wear you down, but motivate you to either do better in that moment, or most importantly, do better for the next patient.
For somebody interested in vascular surgery, are there any major changes coming to the specialty, whether it's therapeutics or surgical techniques or turf wars, that they really should be aware as they're looking to get into it?
There's always going to be turf wars, and I think that should be kind of a call to better ourselves and better define ourselves. There's always going to be, pushing the envelope. Just in my time in training, 15, 20 years ago, the only way to treat an aneurysm was a big belly incision. Then we got to groin cut downs and rudimentary endovascular devices. And, today I can do a complex paravisceral aneurysm through a 5 millimeter incision, 5 to 10 millimeter incision overlying both femoral arteries, and completely close them percutaneously, to where, at the 1 month follow up, you can't even tell that they had an operation from the outside. So the explosion of minimally invasive techniques is going to allow more and more people who say, hey, I have these skills with the wires and catheters to come into quote unquote our turf. And it's going to be up to not only myself, but the next generation to kind of say, you may be able to do that, but we can do it a lot better, and here's how. And eventually, all hardware fails. It's just a matter of whether or not the patient lives long enough for the device to get fatigued, and require an open conversion, in which case you do want them to be at a major aortic referral center, or is the graft going to get infected? It's not just putting in the equipment, it's also being able to manage all of the complications that come from that. And I think that's really where vascular surgeons are going to help be able to define themselves.
You already answered my question about if you would do it all over again. You said a resounding yes. As we wrap up here, any last words of wisdom for that pre-med student, that medical student, or even the Gen Surg resident who's thinking about vascular surgery as a fellowship, for them to continue exploring this field?
I'd welcome them. I think it's one of the more dynamic and rapidly changing surgical disciplines. It's certainly not only in terms of who we can treat and how, but pushing the envelope of, what may be inoperable now. 10 years from now, we'll have a very simple device or a very simple fix that they may very well be a part of developing. It's certainly not for everyone, but for those, like I said, those people who welcome the technically demanding challenge, or the challenge and the opportunities of the spatial challenges that come along with vascular surgery. It's one of those things where if you're good at it and you have the inclination towards it, you're going to love it. Especially for the general surgery resident, who may only do it as an intern or a second year and not get to see the full breadth and just be stuck taking care of the patients. It is so much more than that once you get into the operating room. And if you have the opportunity to rotate as a senior, by all means you should, because it is night and day from just managing them post-operatively or sewing in a simple fistula, which I'm very quickly discovering there's no such thing as a simple fistula. But that's kind of how I thought about it as a second year resident. When you're doing the more challenging cases, either technically or intellectually, it's incredibly rewarding, even though the patients may be challenging at times.
All right, so there you have it. Again, that was Dr. Westley Ohman, a vascular surgeon in the St. Louis area. If you're a resident, a general surgery resident, a medical student, or a pre-med, and you're interested in vascular surgery, I hope this podcast gave you some experience, gave you some information that will help further your decision to go into vascular surgery, or maybe pull you away from it. And that's okay too. That's why we're here, to give you the information to help you make a better decision when it comes to choosing your specialty, so that at the end of it, right after all of your training, you don't come out going, whoa, this is not what I was expecting. That's the worst case scenario. You want to get through it and understand what you're getting yourself into. And that's what we try to do here at the Specialty Stories. I hope you have a great week. We'll see you next time here at Specialty Stories and MedEd Media.